Hi guys, we're going to talk about chapter 43, and it's going to look at alteration and urinary elimination and our genitourinary disorders. Urinary elimination, defined as secretion and excretion of body waste through the renal system. Nurses must be familiar with various GU disorders of children because the alterations in the system may have occurred as an abnormality during fetal development, an infectious process, trauma, neurological deficit, or even a genetic cause. So we just need to be able to determine why this patient has their alteration in the system. So let's get started here. So let's look a little bit at variations in pediatric anatomy and physiology. There are significant differences in anatomy between adult and children. The kidneys are very large compared to the size of their abdomen, which just puts them at more risk for exposure and prone to injury. Their urethra is shorter in all females compared to males, which places them at higher risk for bacteria growth that can lead to UTIs. Glomerular filtration rate is much slower in infants, meaning we're pushing out more fluid quicker without filtering it, which puts them at risk for dehydration. The bladder capacity is very small in the infant, but it reaches adult size by age of 1. And then the reproductive organs are immature at birth, and they mature during our adolescence. Increased androgen, testosterone, and estrogen helps with these organs to mature. Some of the common labs and diagnostics that you will see are, of course, lab work, CBC, BUN, electrolytes, creatinine, total protein, and albumin. Blood work helps to evaluate for infection, nephrotic syndrome, hemolytic uremia, impaired kidney function, or edema. Urinalysis gives us information about the urinary tract and determines treatment. Creatinine clearance helps diagnose impaired renal function. Timed urine collection for 24 hours, a cystoscopy, urodynamic studies, or VCUG. These all evaluate hematuria, recurrent urinary tract infections, and they determine ureteral reflux. Let's see, renal ultrasound, the IVP or intravenous pyelogram is useful in determining kidney size, presence of cysts or tumors, or rejection of kidney transplant. And then renal biopsy helps with diagnosing renal disease or transplant function. So what are some common medical treatments? We can think about urinary diversion. This is done in any situation in which the bladder needs to be removed or isn't functioning correctly. A Foley catheter can help monitor for urethral drainage or irritation. It can monitor for infection, color, consistency, clarity, and amount of urine. A ureteral stent or a nephrostomy tube are indicated for urinary tract anomalies. Suprapubic tube, this is a catheter that's placed in the bladder via the abdominal wall. It's right above that symphysis pubis. Vesicostomy is a stoma in the abdominal wall to the bladder. Appendicovesicostomy uses the appendix to create a stoma on the abdominal wall that allows for catheterization for the bladder. Bladder augmentation uses a piece of stomach or intestine to enlarge that bladder capacity. And dialysis, whether it's hemodialysis or peritoneal dialysis, is just a different medical treatment, and we're going to talk about that here in a little bit. So common medications that we may see, antibiotics, we've talked lots and lots about. It could be oral, parenteral, helps kill bacteria. Anticholinergics cause smooth muscle relaxation of the bladder. DDAVP is an antidiuretic. Corticosteroids we know are anti-inflammatories. ACE inhibitors or other antihypertensives help with vasoconstriction. Imipramine increases the synaptic concentration of serotonin. Immunosuppressants cause immune suppression to prevent a rejection of renal transplants. And albumin increases intravascular oncotic pressure, which helps move fluid from the interstitial to the intravascular space. So let's talk about the nursing process. We always start with assessment. We're going to get a good past medical history. We're going to get a neonatal history, making sure we're aware of the umbilical artery. Was there a presence of a single? Any abdominal mass, chromosome abnormalities, congenital malformations. And then we're going to talk about family history. Do they have family history of renal disease or uropathy, chronic urinary tract infections, getting that just really good family history to try to get some subjective data available. Signs and symptoms of GU disorders. Most of these should be familiar if you've already talked about these in the adult world. Same for the pediatric world. Burning with urination, changes in voiding, maybe they're holding and dumping, foul smelling, discharge, pain, irritation, blood, edema, masses, cramps, distension in that lower belly, nausea, vomiting, right? All of these are going to be signs and symptoms of GU disorders. So we're going to have to, they also can be signs of other things, right? So we just need to make sure we're honing it in to see if this is a GU disorder based off the symptoms that they have. So let's talk about some structural disorders. Several urological conditions are congenital, and they occur as a result of altered fetal development. Some of these we see at birth, but others may not be apparent until later in infancy or childhood when symptoms or complications actually arise. So some of these disorders include hypospadias, obstructive uropathy, hydronephrosis, or vesicoureteral reflux. So when we think about hypospadias, this is a defect in which the opening of their urethral is on the ventral surface of the penis rather than at the end. So that opening is just in the wrong space. Obstructive uropathy is an obstruction at any level along the upper and lower urinary tract. Hydronephrosis is when the pelvis and the calces of the kidney are dilated. And then vesicoureteral reflux is a condition in when urine from the bladder flows back up into the ureters. And we're going to talk about obstructive uropathy and vesicoureteral reflux, specifically for these structural disorders. So obstructive uropathy is any obstruction, we said, along the ureter between the kidney, the pelvis, and the bladder. So you can see your picture there of the anatomy. So this means that some of the common sites for this disease process may include uretopelvic junction. So the pelvis to the ureter may be obstructed. The uretovesical junction, meaning that lower ureter to the bladder, may have the obstruction. Uretocele, which ureter swells into the bladder, so you can see that uretocele there. And then posterior urethral valves. So these are flaps of tissue in the proximal urethra, and this only happens with our male population. So when we think about nursing management for each of these, it's going to be surgical correction. That's going to consist of removing that obstruction and reimplanting the ureters if that's what's necessary. All right, vesicoureteral reflux is a condition in which urine from the bladder flows back up the ureter. So if you can just envision that, that could be a problem, right? Reflux could occur in one or both of the ureters. If the urine is infected, this could expose the kidney to bacteria, which could lead to pyelonephritis. The increased pressure on the kidney can cause renal scarring and lead to hypertension later in life. So assessment findings may include fever, dysuria, frequency or urgency, hematuria, abdomen, or flank pain. As far as nursing management, that's going to include prevention of infection and then post-op care if they have to have a surgical intervention. So as we move into acquired or functional disorders, we can think about urinary tract infections. This is the most commonly affects the bladder and occurs most often because of bacteria ascending to the bladder via the urethra. Enuresis is continued incontinence of urine past the age of toilet training. So just some definitions that are related to enuresis. We can have primary, secondary, diurnal, and nocturnal. So primary enuresis is that the enuresis in the child, they never achieved any voluntary bladder control. So these are the patients maybe with spina bifida. These are the patients that never get potty trained. Secondary enuresis is urinary incontinence in the child who previously had bladder control and now over the last 3 to 6 months doesn't. Diurnal enuresis is daytime, nocturnal is nighttime bedwetting. So just some definitions to be aware of when we're talking about enuresis. Nephrotic syndrome occurs as a result of increased glomerular membrane permeability, which allows abnormal loss of protein in the urine. Acute glomerulonephritis, we're going to talk about that one. So when we talk about glomerulonephritis, this is an acute post-streptococcal glomerulonephritis. Sometimes you'll see it as APSGN. This is a condition in which immune processes injure the glomeruli, which causes inflammation, which results in altered glomerular structure and function of the kidneys. It typically occurs after a respiratory or skin infection with a nephrogenic strain of group A strep. So if you can think again of our patient with group A strep, right? If we don't treat group A strep, we've already talked about several disorders that it could lead to. But this is an additional one, right? Glomerulonephritis usually occurs after this type of a group A strain, whether it be respiratory or skin. There's no specific treatment for glomerulonephritis. We're just really aiming at maintaining fluid volume and then managing any hypertension that may be going on. When we think about assessment and management of glomerulonephritis, some of the common signs and symptoms that we're going to see are just that generalized edema. This occurs because of that decreased glomerular filtration that's trying to push out that extra protein. We can also see fever, lethargy, headache. They're going to have decreased urine output. They're going to complain of belly pain, vomiting, and even anorexia. We also need to make sure we're assessing blood pressure. We're auscultating heart sounds for any gallops and lung sounds for crackles. We'll also look at urine for any gross hematuria. You might hear them say with glomerulonephritis, they have cola-colored urine or tea-colored urine because of all of the blood, that gross hematuria that is occurring. So how are we going to help these patients manage this disorder? We're going to administer hypertensives and diuretics as those are ordered. We're going to maintain sodium and fluid restrictions during that initial edematous period. We want to make sure we're weighing our child daily on the same scale with the same clothing every day at the same time. Hypertension can cause encephalopathy and seizures, so we want to make sure we're really assessing that neurological system really well. If the child can be managed at home, we're going to educate our family to monitor blood pressure and diet restrictions. Education at home should also include monitoring for proteinuria or hematuria. We're going to recommend no strenuous activity or contact sports at this time during this acute time. And absolutely, they cannot take NSAIDs. That's going to cause further decrease in that glomerular filtration. So we want to make sure they are avoiding all NSAIDs. So this is just a cute recap for you, for you visual learners, right? He's holding his head because he has a headache. He has increased blood pressure. which could cause encephalopathy and seizures. So we have to make sure we're watching that neurostatus. You're going to see generalized edema, lethargic, low-grade fever, weight gain, right? We're going to be weighing these kiddos every single day. And then we're going to look for all that urine, right? Proteinuria, hematuria. If they got hematuria, sometimes you hear it as tea-colored, sometimes you hear it as cola-colored. And then we can just see there on the left what causes glomerular inflammation, and it's just that decreased glomerular rate, usually caused by a recent strep infection. Okay, moving on. Hemolytic uremic syndrome. 3 defined features that include hemolytic anemia, thrombocytopenia, and acute renal failure. So if you have hemolytic uremic syndrome, it could be defined as those 3 things: hemolytic anemia, thrombocytopenia, or acute renal failure. And then renal failure, acute or chronic, is also going to talk about here. There's a hemolytic uremic syndrome, usually preceded by diarrheal illness, including hemorrhagic colitis. There's damage to the microthrombotic events in the kidneys. And then again, it's characterized by those 3 things: hemolytic anemia, thrombocytopenia, and acute renal failure. So again, failure. All right, renal failure is a condition where the kidneys cannot concentrate urine or excrete waste products. Acute renal failure is sudden, but often reversible. Acute conditions that progress can turn into chronic end-stage renal disease. So we can see why it's really important to recognize this quickly. They could be in acute or chronic. When they're in acute, again, it's going to progress to chronic. We can talk about fluid overload, which could lead to hypertension, pulmonary edema, congestive heart failure in children, hypovolemic shock, things like that. It commonly does occur as a result of decreased renal perfusion. So some of the medications commonly used that can reduce our renal function. So if your patient is on lots of cephalosporins, that's going to, you may see an increase in BUN and creatinine, and then nephrotic drugs such as aminoglycosides, sulfonamides, vancomycin, and NSAIDs. So if you're getting a really good health history, right, and you're talking about what medications do you take, and you hear them talk about cephalosporins or nephrotic drugs, it should be a red flag for you to seek out more clarification. We do see these medications often used in our pediatric patients, so as nurses, we just need to be aware that these can cause renal dysfunction. All right, so let's talk about nursing management. That's going to include treating the underlying cause, managing that hypertension. We're carefully monitoring the blood pressure. We're administering any antihypertensives that are prescribed. We may need to give hypertensive medications IV and then monitor that blood pressure until it returns to normal. We're going to restore fluid and electrolyte imbalance. So how is that done? We're going to monitor vital signs frequently. We're going to assess that urine-specific gravity. Excuse me. We're going to maintain strict records of intake and output. We're going to administer diuretics as ordered. When that urine is restored, you're going to see a significant diuresis that will occur. Monitor for signs of hypokalemia and hypocalcemia. So the drug of choice here is administration of polystyrene sulfonate to help remove potassium by exchanging it for sodium. If our kidneys are really not responding well and they're not sending out erythropoietin, we may need to administer packed red blood cells. Excuse me, so sorry guys. And then dialysis may become necessary if none of that works. So we've talked about administration of the med. Now we need to provide family education. Fluid restriction, right? They've got lots of fluid on them, probably don't want to add to it. Saving all the voids for observation and measurement, and about dialysis if our patient's going to have dialysis. So chronic complications of acute renal failure include water intoxication and hyponatremia. Remember, they have lots and lots of swelling and edema, so we need to make sure we're watching that. Hyperkalemia, hypertension, anemia, seizures, and cardiac failure with pulmonary edema. All significant complications for our acute renal kids. End-stage renal disease. This is chronic renal failure that requires long-term dialysis or kidney transplant. Often results from a structural defect rather than something nephrotoxic like medications. Complications, they usually occur because the uremia toxins deplete erythrocytes and the kidneys can't make erythropoietin, which causes severe anemia. And then hypertension and heart failure are also significant complications. They can be seen both in acute, but they can also occur in our end-stage kiddos. Physical assessment findings when we are assessing our kiddos, if we see a peritoneal catheter, we'll want to assess the site for any or absence of drainage, any bleeding or redness. If the child is undergoing hemodialysis, we'll want to assess the fistula or graft site for the presence of a bruit and a thrill. We can listen for a bruit, which is a rumbling sound, and we can feel for a thrill, which is a vibration. Labs and diagnostics are going to show low hemoglobin, low hematocrit, increased uric acid, and increased creatinine. As far as nursing management, that's going to include growth and development, right? We're going to plot them. We're going to see where there are as far as development. We're going to remove waste products and maintain fluid balance because of our dialysis. We're going to minimize those complications that we've talked about. Daily protein, you can see there for growth, sodium, potassium restrictions, and then we really want to support and educate our family. And that's going to be all encompassed in that nursing management. And so like any other disorder, we need to look at the psychosocial well-being. We may want to refer our children and families to the hospital social worker or counselor as needed if you see any signs of depression or anxiety. We can ensure that the family is aware of financial and support resources also within that community. So let's look a little bit at dialysis. We've talked about peritoneal and hemodialysis. So let's break it down just a little bit here. Peritoneal dialysis is the preferred method of dialysis for children. It uses the patient's abdomen as a semi-permeable membrane to help remove excess fluid and waste products. The advantages for this are improved growth, increased independence, and a steadier state of electrolyte balances. Another advantage for peritoneal dialysis is that it can be done from home. If the parent sees abdominal distension is occurring with peritoneal dialysis, then we just need to make sure all of that fluid is getting out and the fluid is coming out clear and not cloudy. So lots of advantages for our peritoneal dialysis kids, and for that reason, it's the preferred choice. So some of the risks, though, that might be associated with peritoneal dialysis are listed in box 43.2 in your book, and I have just placed it here so you can see some of those risks. If dialysis fails, kidney transplant could happen. Living relative kidney transplants decrease the risk of failure versus a cadaver transplant. Lots of additional assessment and medications and educations would be required if our kiddos had to be transplanted. On the flip side, hemodialysis, it removes toxins and excess fluid from blood by pumping the blood through a dialysis machine and then reinfusing it back to the body. This is typically done 3 times a week. It requires vascular access and a special dialysis equipment. So, meaning this cannot be done at home. So some of the disadvantages mean that they may be missing school, they may be missing other activities, the access site may become more infected, and they have to have, excuse me, a stricter diet between treatments. All right, briefly, we're going to talk about female reproductive organ disorders. Labial adhesions is a partial or complete adherence of the labia minora that could result in urinary stasis behind the labia. So if you can just picture those, the lips of the labia, right, they're stuck together, meaning no urine is coming out, and it could create some stasis. Vulvovaginitis is an inflammation of the vulva and the vagina. Because of that inflammation, bacterial or yeast overgrowth could occur. Chemical factors include bubble baths, soaps, perfumes. So education on not sticking your kiddo in a bubble bath for long periods of time. Poor hygiene could also be a cause for this. Some associated factors that could cause it are tight clothing that could cause a heat rash in that perineal area. Persistent scratching of the irritated area could result in some superficial skin infection. So as far as nursing management, teaching appropriate hygiene, wearing cotton underwear, changing underwear daily, administering topical or oral medications as ordered. Pelvic inflammatory disease is another female reproductive organ disorder. STIs, you've probably talked about, and then we can also talk about menstrual disorders, primary and secondary, amenorrhea, you can see those. So several female reproductive organ disorders that could be discussed. When we flip this coin, and so we do male reproductive disorders, phimosis or paraphimosis is, with phimosis, the foreskin cannot be retracted. Paraphimosis is a more serious, and it's characterized by retraction of the phimotic prepuce, which can cause a restricted band behind the glands of the penis and result in incarceration if we leave it unattended. Nursing management of phimosis or paraphimosis could be surgical intervention in the way of a circumcision. So benefits of a circumcision, you can see decreased incidences of UTIs, STIs, HIV, penile cancer, cervical cancers in female partners. Complications are rare, but could include bleeding, penile adhesions, imperfect amount of foreskin removal, and medial stenosis. Cryptorchidism, also known as an undescended testicle. That would have been way easier just to say it. Undescended testicle is a male reproductive disorder. Hydrocele or varicocele hydroceles are a fluid in the scrotal sac that usually are benign and self-limiting. Testicular torsion, about that one a little bit. This is a testicle is abnormally attached to the scrotum and it's twisted. This typically requires immediate surgery because ischemia can result if the torsion is left untreated. It could also lead to infertility. This could occur really at any age, but usually it's in boys 12 to 18 years old. Epididymitis, that is an inflammation of the epididymis caused by an infection with bacteria, most common cause of pain in the scrotum. It rarely occurs before puberty. If it does, it may occur as a result of a urethral or bladder infection related to some type of urogenital anomaly. So therapeutic management is going to be directed towards eradicating that bacteria. If that's left untreated, scrotal abscess, testicular infarction, or infertility could occur. Oh, and that concludes chapter 43. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.